Are you suffering from sciatic nerve pain that runs down your leg and can't find lasting relief? If you're over 60, you need to know that there are age-specific factors that may be silently and dangerously worsening your sciatic pain. Today, I'll reveal crucial information every mature adult needs to know about the sciatic nerve, especially those warning signs that can indicate serious complications if not treated properly. I'd love to hear where you're watching from today. Leave a comment below telling me your age and how long you've been living with sciatica. And don't forget to subscribe to the channel and turn on notifications so you don't miss any valuable tips on health and wellness after 60. The sciatic nerve is the largest and longest nerve in the human body, extending from the lower back to the toes. It arises from the nerve roots of the lumbar spine, specifically the L4, L5, and first three sacral vertebrae. For people over 60, this nerve becomes particularly vulnerable due to a series of natural physiological changes of aging that often go unnoticed until the pain becomes unbearable. Statistically, about 40% of people develop sciatica at some point in their lives, but this percentage jumps to a staggering 85% among those over 60. This is no coincidence. The natural aging process brings with it significant structural changes in the spine that create an environment conducive to sciatic nerve compression. Notable among these changes is the dehydration of the intervertebral discs, which lose up to 20% of their water content after age 60, making them less flexible and more prone to protrusions and herniations that can compress the sciatic nerve. Furthermore, thickening of the spinal ligaments, scientifically known as ligamentous hypertrophy, reduces the space available for the nerve to pass through, creating a condition called spinal stenosis. This condition is found in more than 60% of adults over 65, although many initially experience no symptoms. The growth of osteophytes, popularly known as parrot's beaks, also contributes to the reduction of neural space and can exert direct pressure on the sciatic nerve. The paraspinal and gluteal muscles also undergo significant changes after age 60. Sarcopenia, the natural age-related loss of muscle mass, particularly affects the stabilizing muscles of the spine. Studies show that people over 60 lose an average of 3% to 8% of muscle mass per decade, and this loss accelerates after age 70. When the muscles that support the spine weaken, the additional load falls on passive structures such as discs, ligaments, and joints, dramatically increasing the risk of sciatic nerve compression. But what makes this situation even more concerning for people over 60 are the age-specific risk factors that can transform simple sciatic pain into a debilitating condition. Osteoporosis, present in more than 30% of women and 20% of men over 60, makes the bones of the spine more fragile and prone to compression fractures. These fractures can drastically alter the anatomy of the spine and compress the sciatic nerve in ways that conventional treatments may not be able to resolve. Type 2 diabetes mellitus, which affects approximately 25% of adults over 60, represents another critical risk factor. Elevated blood glucose levels cause diabetic neuropathy, a condition that makes nerves, including the sciatic nerve, more sensitive to pain and less able to recover from injury. When diabetic neuropathy combines with mechanical compression of the sciatic nerve, the resulting pain can be excruciating and extremely resistant to conventional treatments. Hormonal changes also play a key role. In postmenopausal women, declining estrogen levels affect not only bone density, but also the hydration of the intervertebral discs and the elasticity of the spinal ligaments. Estrogen has natural anti-inflammatory properties, and its reduction can intensify inflammatory processes that affect the sciatic nerve. In men, the gradual decline in testosterone levels after age 60 is associated with loss of muscle mass and reduced bone density, creating similar conditions of vulnerability. What many older adults don't realize is that sciatica pain after age 60 often presents different characteristics than sciatica in younger people. While younger people typically experience sharp, well-localized pain, older adults may develop diffuse pain, persistent burning, progressive numbness, and even significant muscle weakness in the affected leg. These symptoms can be mistakenly attributed to normal aging, delaying proper diagnosis and treatment. The first critical factor that everyone over 60 needs to be aware of is age-related piriformis syndrome, a condition that becomes dramatically more common and dangerous after age 60, but is rarely correctly diagnosed by health professionals. The piriformis muscle is a small muscle located deep in the gluteal region that externally rotates the hip and stabilizes the pelvis during walking. In approximately 15% of the population, the sciatic nerve passes directly through this muscle. But in people over 60, specific structural changes make this anatomy much more problematic. As we age, the piriformis muscle undergoes a process called muscle fibrosis, where healthy muscle tissue is gradually replaced by less elastic fibrous tissue. This transformation causes the muscle to lose its ability to fully relax, remaining in a state of constant partial contraction. When this happens, any sciatic nerve that passes through or near the piriformis is under constant pressure, creating pain that can be confused with a herniated disc or other more serious conditions. Recent studies show that piriformis syndrome accounts for up to 30% of sciatic pain cases in people over 65, but only 8% receive the correct diagnosis initially. This is because symptoms can be very similar to those of other conditions, and many doctors are unfamiliar with the specific changes that aging causes in this muscle. Piriformis fibrosis is accelerated by common factors in old age, such as prolonged sedentary lifestyle, arthritis in the hip joints, and even the use of canes or walkers that alter walking patterns. What makes this condition particularly insidious is that it develops gradually over years. Many people begin by experiencing mild discomfort in the gluteal region that progressively worsens, especially when sitting for prolonged periods or rising from chairs. Over time, this pain radiates down the leg, following the exact path of the sciatic nerve. The crucial difference is that while sciatic pain caused by a herniated disc usually improves with rest, age-related piriformis syndrome tends to worsen with prolonged inactivity. Early identification of this condition is crucial because treatment is completely different from that used for other causes of sciatica. Traditional therapies such as anti-inflammatories and conventional physical therapy can even worsen the condition if not specifically adapted for piriformis fibrosis. The fibrotic muscle responds best to specific myofascial release techniques, targeted stretching, and eccentric strengthening that help break down fibrous adhesions and restore muscle elasticity. The second critical factor is degenerative lumbar spinal stenosis, a condition that silently affects more than 70% of people over 70, but can remain asymptomatic for years before causing devastating sciatic pain. Spinal stenosis refers to the narrowing of the spinal canal through which the spinal cord and the nerve roots that form the sciatic nerve pass. This narrowing occurs due to the thickening of structures that naturally deteriorate with age. The intervertebral discs lose height, the ligamentum flavum hypertrophy, and the facet joints develop osteoarthritis with the formation of osteophytes. The degenerative process begins subtly around age 50 but accelerates significantly after age 60. Initially, the spinal canal maintains enough space to accommodate neural structures even with these changes. However, there is a critical point where the available space becomes insufficient, and any movement or posture that further reduces this space results in compression of the sciatic nerve roots. This phenomenon explains why many people over 60 develop sciatic pain that worsens significantly with walking or standing for prolonged periods, but improves dramatically with sitting or bending forward. Neurogenic claudication, a characteristic symptom of spinal stenosis, is often confused with vascular problems in older adults. Patients describe pain, numbness, and weakness in the legs that begin after walking a certain distance and are relieved only by sitting down or leaning forward, such as when pushing a shopping cart. This flexed position increases the diameter of the spinal canal by up to 25%, providing temporary relief from neural compression. What makes spinal stenosis particularly dangerous in people over 60 is its inevitable progression if not treated properly. Unlike other causes of sciatica, which can be episodic, spinal stenosis tends to worsen progressively, increasingly limiting the ability to walk and perform daily activities. Longitudinal studies show that people with symptomatic spinal stenosis who do not receive adequate treatment experience a 40% decrease in walking distance every 2 years. Early detection of spinal stenosis is crucial because conservative treatments are very effective when implemented in the early stages. Specific spinal flexion exercises, core strengthening, and decompression techniques can significantly slow the progression of the condition and maintain functionality for many years. Furthermore, early recognition allows for appropriate planning of more invasive interventions, if necessary, at a time when the patient still has good functional reserves. The third critical factor that deserves special attention is age-related lumbar segmental instability, a condition where one or more segments of the lumbar spine lose their ability to maintain normal positions during movement. This instability results from the combined degeneration of intervertebral discs, facet joints, and supporting ligaments, creating abnormal movement between the vertebrae that can intermittently compress the sciatic nerve roots. After age 60, intervertebral discs lose not only height, but also their ability to control movement between vertebrae. The nucleus pulposus becomes less hydrated, and the annulus fibrosus develops fissures that allow excessive movement. Simultaneously, the facet joints develop osteoarthritis, losing their ability to properly guide vertebral movement. The result is a spinal segment that moves erratically and unpredictably and may slip slightly during normal activities. This segmental instability creates a unique situation where sciatic pain can be intermittent and related to specific positions. Patients often report that certain movements, such as rotating the trunk or leaning forward, trigger intense pain that radiates down the leg, but which may disappear completely when they return to a neutral position. This variability in symptoms often confuses both patients and healthcare professionals, leading to misdiagnosis and ineffective treatments. The first warning sign that requires immediate medical attention in people over 60 is cauda equina syndrome, a neurological emergency that can result in permanent paralysis and loss of sphincter control if not treated within 48 hours. The cauda equina refers to the group of nerves that extend from the spinal cord in the lower lumbar region, forming a structure resembling a horse's tail. In mature adults, this region becomes particularly vulnerable due to the progressive narrowing of the spinal canal and the increased propensity for massive central disc herniations. What makes this condition especially insidious in people over 60 is that the initial symptoms can be subtle and easily confused with normal worsening sciatic pain. Early signs include bilateral sciatic pain, meaning it affects both legs simultaneously, something that rarely occurs in common cases of sciatica. This bilateral pain indicates massive central compression affecting multiple nerve roots simultaneously. Studies show that in people over 65, cauda equina syndrome has a more insidious presentation, with symptoms that can develop over days or even weeks, unlike the typical acute presentation in younger people. Changes in sensation in the perineal region, known as saddle anesthesia, are another cardinal sign that every mature adult should be aware of. This area includes the genitals, anus, and inner thighs, basically all areas that would come into contact with a saddle if the person were riding a horse. Loss of sensation in this region indicates severe compression of the nerves that control these areas and may precede loss of bladder and bowel control. In older adults, this change may be gradual and initially confused with age-related urological or bowel problems, dangerously delaying diagnosis. Changes in bladder function represent one of the most critical and often overlooked signs. In mature adults, these changes may begin as a decreased force of the urinary stream, a feeling of incomplete bladder emptying, or the need to strain to urinate. Many people mistakenly attribute these symptoms to prostate problems in men or hormonal changes in women, failing to realize that they may be related to neurological compression. Acute urinary retention, where the person is unable to urinate despite the urge, is a sign of absolute emergency that requires immediate decompression surgery. The second crucial warning sign is progressive motor weakness, especially when it affects specific muscles that are indicators of compression of particular nerve roots. In people over 60, this weakness may develop gradually and may initially be attributed to normal aging or physical deconditioning. However, there is a fundamental difference between age-related weakness and neurological weakness. The former affects muscle groups across the board, while the latter affects specific muscles innervated by particular nerve roots. Weakness of the tibialis anterior muscle, responsible for lifting the toe upward, is one of the earliest and most specific signs of L4 root compression. This weakness initially manifests as difficulty walking on tiptoe or frequent tripping due to the inability to properly lift the toe while walking. Many mature adults develop what we call a shoehorn gait, where they drag their foot slightly on the ground or need to exaggeratedly lift their knee to prevent the toe from touching the ground. This change should never be considered normal aging and requires urgent neurological evaluation. Weakness of the plantar flexor muscles, which control the ability to stand on tiptoe, indicates compression of the S1 and S2 roots. This weakness is particularly dangerous in older adults because it significantly compromises balance and dramatically increases the risk of falls. The inability to stand on tiptoe for more than 10 seconds or perform repeated tiptoe raises indicates significant neurological weakness that requires immediate investigation. Studies show that adults over 65 who develop plantar flexor weakness due to neurological compression have a 300% increased risk of serious falls within the following 6 months. The third key warning sign is altered tendon reflexes, especially the Achilles and patellar reflexes. In people over 60, assessing these reflexes becomes even more important because subtle changes can indicate progressive neurological compression before more obvious symptoms develop. The Achilles reflex, tested by tapping the Achilles tendon with a neurological hammer, assesses the integrity of the S1 and S2 nerve roots. A decrease or absence of this reflex on one side compared to the other indicates significant compression of these roots. What makes this assessment particularly relevant in mature adults is that reflex changes may be the first and only sign of nerve compression in the early stages before severe pain or weakness develops. This offers a window of opportunity for early intervention that can prevent permanent neurological deterioration. The patellar reflex, tested by tapping the patellar tendon below the kneecap, assesses the L2, L3, and L4 roots. Changes in this reflex may indicate compression at higher levels of the lumbar spine. Reflex asymmetry is particularly significant. When a reflex is present and normal on one side but diminished or absent on the other, this clearly indicates unilateral neurological compression that requires investigation. In people over 60, this asymmetry should never be attributed to normal aging, as the aging process affects both sides equally. Serial documentation of these reflexes over time allows for the detection of progressive neurological deterioration and appropriate treatment adjustments. The fourth critical warning sign is a change in pain pattern, especially when sciatica becomes constant and unresponsive to position changes or standard medications. In mature adults, typical sciatica usually improves with rest, position changes, or anti-inflammatory medication. When the pain becomes constant, present even during nighttime rest, and unresponsive to standard conservative measures, this may indicate severe neurological compression or even more serious pathological processes such as tumors or infections. Nighttime pain that wakes the patient is particularly concerning. Sciatica pain related to mechanical spinal problems typically improves with rest and worsens with activity. When pain persists or even worsens during nighttime rest, especially if it wakes the patient from sleep, this raises suspicion of non-mechanical processes such as tumors, infections, or severe inflammation, which require urgent investigation with advanced imaging tests and possibly a biopsy. The primary prevention protocol specific to mature adults is based on the concept of neurological reserve, a term that refers to the nervous system's ability to resist injury and recover from trauma. After age 60, this reserve decreases significantly due to natural physiological changes, making it essential to implement specific preventive strategies to compensate for these limitations. The first component of this protocol is the Progressive Spinal Mobility Program, specifically designed to maintain the flexibility of the structures peripheral to the sciatic nerve without overloading an already vulnerable spine. This program begins with gentle mobilization movements of the lumbar spine in a reduced range of motion, focusing on maintaining hydration of the intervertebral discs through controlled movements that promote nutrient diffusion. The disc pumping technique involves slow, controlled flexion and extension movements of the lumbar spine, holding each position for 5 to 10 seconds, repeating 10 to 15 times, 3 times a day. These movements should be performed within a pain-free range of motion, never forcing beyond what is comfortable. Biomechanical studies show that this type of cyclical movement alternately increases positive and negative intradiscal pressure, promoting the entry of nutrients and the removal of metabolic products from the intervertebral discs. Specific mobilization of the sciatic nerve in mature adults requires adapted techniques that consider the reduced neural elasticity and greater propensity for irritation. The modified neural gliding technique for older adults begins with the patient lying on their back, one leg extended on the floor and the other gently raised to the point where a slight stretch is felt in the back of the thigh. Instead of forcing a greater range of motion, the movement consists of gently flexing and extending the ankle of the elevated leg, creating a gentle gliding of the sciatic nerve without excessive mechanical stress. This movement should be performed 20 to 30 times, twice a day, always respecting the threshold of tolerable discomfort. Core stabilization in mature adults differs significantly from the approach used in younger people. The focus shifts from high-intensity exercises to sustained, low-intensity activation that can be maintained throughout the day. The deep abdominal breathing with pelvic floor activation exercise exemplifies this approach. Sitting in a chair with their back supported, the patient places one hand on their chest and the other on their abdomen, inhaling slowly through the nose, allowing only the hand on their abdomen to move, while gently contracting the pelvic floor muscles, as if stopping the flow of urine. This contraction should be held for 10 seconds and repeated 10 times, several times a day. Strengthening the gluteal muscles is critical in mature adults because these muscles often become inactive due to a sedentary lifestyle, a phenomenon known as gluteal amnesia. The gluteus maximus muscle is the major stabilizer of the pelvis, and its weakness forces compensations that can overload the lumbar spine and compress the sciatic nerve. The modified gluteal bridge exercise is performed lying on your back with your knees bent and feet flat on the floor, contracting your glutes to lift your hips off the floor, maintaining a straight line from your knees to your shoulders. For mature adults, the focus is on the quality of the gluteal contraction, not the height of the lift. The contraction should be held for 5 to 10 seconds, repeated 15 to 20 times, twice a day. The acute pain management protocol for mature adults recognizes that the inflammatory response in this population is often exaggerated and prolonged. The peace and love principle, adapted for the mature age group, guides initial treatment. Peace represents immediate actions. Protect the affected area by avoiding movements that exacerbate pain. Elevate the affected leg when possible to reduce edema. Avoid anti-inflammatory drugs for the first 48 hours to avoid interfering with the natural healing process. Apply gentle compression with an elastic bandage if edema develops, and educate about warning signs that require immediate medical attention. Love represents the actions for long-term recovery. Gradually optimize load through controlled and progressive movement. Vascularization through age-appropriate low-impact cardiovascular activity, and progressive exercise respecting the specific functional limitations of mature adults. For people over 60, the load optimization phase should be particularly cautious, starting with pain-free movements and progressing very gradually over weeks or months, not days. Pharmacological management in mature adults requires special considerations due to age-related changes in pharmacokinetics and pharmacodynamics. The liver and kidneys, responsible for drug metabolism and elimination, function less efficiently after age 60, resulting in a higher risk of drug accumulation and adverse effects. Non-steroidal anti-inflammatory drugs, commonly used for sciatica, present significantly increased risks in mature adults, including gastrointestinal bleeding, impaired renal function, and interactions with cardiac medications frequently used in this age group. Safer alternatives include the judicious use of paracetamol as a first-line treatment for mild to moderate pain, always respecting the maximum dose of 3 grams per day in healthy adults, but reducing it to 2 grams in patients with liver impairment or alcohol use. Muscle relaxants should be avoided or used with extreme caution due to the increased risk of falls, mental confusion, and drug interactions. When necessary, they should be prescribed at the lowest effective dose and for the shortest possible duration, preferably not exceeding 7 to 10 days. The application of heat and cold should follow specific protocols for mature skin, which has lower thermal sensitivity and a higher risk of burns. Cryotherapy should be applied for periods no longer than 15 minutes, with a textile barrier between the ice and the skin, checking skin color every 5 minutes. Thermotherapy should use lower temperatures than for younger people, not exceeding 40 degrees Celsius, and for periods limited to 20 minutes to avoid excessive vasodilation, which can cause postural hypotension in mature adults. The return to daily activities protocol follows the principle of stepped functional progression, where each activity level is mastered before advancing to the next. The first level includes basic daily living activities such as dressing, bathing, and walking around the house for short periods. The second level adds light household activities such as preparing simple meals and cleaning tasks that do not involve excessive bending or heavy lifting. The third level incorporates community activities such as driving for short periods, shopping, and participating in social activities. Each level must be maintained for at least 1 week without symptom exacerbation before progressing to the next. Modifying the home environment is a crucial aspect of secondary prevention in older adults. This includes elevating toilet seats to reduce lumbar flexion during use, installing grab bars in bathrooms, using long-handled toilet shoes to prevent excessive bending, and rearranging cabinets to keep frequently used items at accessible heights without the need for excessive squatting or stretching. These modifications not only reduce the risk of sciatica exacerbation, but also significantly decrease the risk of falls, a major concern in older adults with sciatica, which can affect balance and proprioception. The most important considerations for older adults with sciatica involve recognizing that this condition represents much more than a simple, transient discomfort. After age 60, sciatica often signals significant structural changes in the spine that, if not properly managed, can result in progressive functional deterioration and a substantial loss of quality of life. The first fundamental consideration is understanding that aging does not make sciatica inevitable or untreatable, but rather requires a more sophisticated and personalized approach that considers the specific limitations and vulnerabilities of this age group. The interaction between sciatica and other common conditions in older adults creates a complex scenario that demands multidisciplinary attention. The simultaneous presence of diabetes mellitus, hypertension, osteoporosis, and arthritis can significantly influence both the clinical presentation and the available therapeutic options. For example, diabetic neuropathy can mask or intensify sciatica symptoms, making differential diagnosis extremely challenging. Diabetic patients with sciatica may experience more intense symptoms and slower recovery due to impaired neural healing and a greater propensity for chronic inflammatory processes. Osteoporosis is a particularly critical consideration because it significantly limits spinal exercise and manipulation options. Exercises involving spinal flexion, rotation, or impact should be avoided or significantly modified to prevent vertebral compression fractures. Paradoxically, physical inactivity to protect the osteoporotic spine can accelerate bone loss and muscle deconditioning, creating a vicious cycle of functional deterioration. The solution lies in supervised exercise programs that emphasize isometric strengthening, progressive resistance exercises with appropriate loads, and activities that promote balance and proprioception without overloading the vulnerable spine. Polypharmacy, common in older adults who frequently take multiple medications for different conditions, requires special consideration when managing sciatica. Many medications used to treat other conditions can interfere with sciatica treatment or exacerbate its symptoms. Diuretics can cause dehydration, which negatively affects the health of intervertebral discs. Beta blockers can reduce exercise capacity. Sedatives and anxiolytics can increase the risk of falls in patients already compromised by pain and functional limitations. A comprehensive medication review is essential to identify potential interactions and optimize the therapeutic regimen. Nutrition takes on increased importance in older adults with sciatica due to increased nutrient requirements for neural repair and inflammation reduction, combined with the frequently impaired absorption and decreased appetite common in this age group. Protein becomes especially critical, with requirements increasing to 1.2 to 1.6 grams per kilogram of body weight to combat sarcopenia and promote neural recovery. High-quality protein sources should be distributed throughout the day to optimize muscle protein synthesis. Omega-3 fatty acids, particularly EPA and DHA, demonstrate potent anti-inflammatory effects that can reduce neural inflammation and promote recovery. The recommended dose is 2 to 3 grams per day, preferably from marine sources. Specific precautions and contraindications for mature adults with sciatica reflect this population's greater vulnerability to complications and reduced physiological reserve to tolerate aggressive treatments. High-velocity, low-amplitude spinal manipulations should be avoided or performed with extreme caution due to the increased risk of vertebral fractures, arterial injury, and exacerbation of spinal stenosis. Deep tissue massage may be contraindicated in patients taking anticoagulants due to the risk of significant bruising. High-intensity exercise can precipitate cardiovascular events in patients with undiagnosed underlying heart disease, which is common in this age group. Heat application should consider the decreased thermal sensitivity and more fragile skin of mature adults. Temperatures that are comfortable for younger people can cause burns on mature skin. Heating devices should never be applied directly to the skin, and the temperature should be carefully monitored. Patients with peripheral neuropathy, common in diabetics, are at particularly high risk of thermal burns due to decreased sensitivity. Hydrotherapy, while beneficial, requires special precautions regarding water temperature and the risk of falling on wet surfaces. When to seek medical help becomes a crucial question for mature adults because the window of opportunity for effective intervention may be narrower than for younger people. Any sudden change in the intensity, location, or nature of pain should be evaluated immediately. The development of progressive weakness, changes in bladder or bowel function, or pain that does not respond to conservative measures within 48 to 72 hours requires urgent medical evaluation. The presence of fever associated with sciatica may indicate a spinal infection, a medical emergency that requires immediate antibiotic treatment. Mature adults should seek medical evaluation if sciatica significantly interferes with sleep for more than 3 consecutive nights, as sleep deprivation can precipitate a cascade of health problems, including cognitive impairment, increased risk of falls, and exacerbation of pre-existing medical conditions. Any history of cancer, even remotely, requires immediate investigation of new sciatica to rule out spinal metastases. Unintentional weight loss associated with sciatica may indicate an underlying malignancy and requires urgent cancer evaluation. The implementation protocol for mature adults should be initiated gradually and with appropriate supervision. The first week should focus exclusively on education about the condition, environmental modifications, and basic pain relief techniques. The second week introduces gentle, non-load-bearing mobilization movements. The third and fourth weeks add low-intensity strengthening exercises. Only after 4 weeks of successful implementation should increases in program intensity or complexity be considered. This extended schedule recognizes that mature adults require more time for neural and tissue adaptation, but also offers better long-term adherence when progress is gradual and sustainable. If this video was helpful to you and provided important insights into the specific care every mature adult should take with sciatic pain, please click the like button so more people your age can access this crucial information. Leave a detailed comment describing your experience with sciatic nerve pain, your age, how long you've lived with the condition, and what the biggest challenges you faced were. These stories are extremely valuable to other viewers who may be going through similar situations and will feel less alone in their recovery journey. Subscribe to the channel and turn on notifications to receive specialized content on senior health, focusing on practical, evidence-based solutions that truly work for people over 60. Share this video with family, friends your age, or peer groups who might benefit from this information. Often, knowledge shared at the right time can prevent serious complications and significantly improve the quality of life of a loved one. And let us know in the comments what specific topic about sciatic nerve and spinal health you'd like to see in the next video, always focusing on the needs and specificities of mature adults. Your suggestions guide our content and ensure we're addressing exactly the topics that matter most to you and your family.